Greetings and welcome to Enhancing Personalized Medicine in Advanced Ovarian Cancer, expert guidance on integrating the latest updates on PARP inhibitors and novel therapeutic innovations into your clinical practice. This is a peer-review live program, and it's my honor to be with you from Phoenix, Arizona, where I am professor at both medical schools here in Phoenix, Arizona College of Medicine and Creighton University. And I'm joined by my colleague, a professor of gynecologic oncology at Duke University, Angeles Secord. Angeles, thank you so much for being here today.
Thank you, Brad, for inviting me. It's a pleasure to be here.
I'm so excited. There is so much going on in the field of ovarian cancer, and we're going to have a very focused hour-long program, and I really appreciate all the preparation that you've put into this.
Absolutely. I mean, with PARP inhibitors for the last few years, it's like the great data just keeps coming, and it's so wonderful to be able to offer this information to our patients and these therapies.
I always love your enthusiasm and energy, so that's great. So this is 4 sessions. I'll begin with an introduction to PARP inhibitors. Angeles, if I can call you Angeles, I'm sure I can. We'll examine the latest evidence of PARP inhibitors. We'll have some case discussions and questions and answers, and then we'll talk about novel innovations that hopefully will be in the clinic soon. So I'd like to begin this introduction by discussing targeting the DNA damage response pathway, understanding the rationale for PARP inhibition and genomic testing in ovarian cancer. And I'd like to begin with this key concept. Ovarian cancer is not a mutationally driven cancer. It's not like you can do a molecular analysis and say, oh, that's the driver, that's the EGF, that's the ALK, that's the HER2 new. They don't exist. So what we've done is, especially Angeles and I and our friends and you, to target the microenvironment through angiogenesis and to target what ovarian cancer really is, a disease of genomic instability. And so we've taken a lot of time and effort to understand the DNA damage response pathway and identify drug targets that we can use in the clinic to help patients live longer and better. So I think we're all aware that single-stranded breaks are common almost on a daily basis. You see this on the left. These are generally repaired through base excision repair, and which is involved with poly-ADP ribose polymerase, or PARP, which I'll talk about. You can get double-stranded breaks, and we'll talk about how double-stranded breaks are repaired. And then certainly cytotoxic agents such as platinum can cause adducts. And there are other nucleotide mutations, substitutions, deletions, and insertions. So what PARP does is PARP is part of the process whereby double-stranded DNA breaks are repaired. So if you, me, my chromosomes, DNA breaks, sister chromatid will be lined up to the homolog and it'll be recombined. Homologous recombination. And so that's what we abbreviate as HR. There are other ways where it can be non-homologous end joining, which has a very low fidelity, okay? But this homologous recombination can be targeted because the deficit in homologous recombination is BRCA or BRCA-like genes. So that's really the key point here. So what we do is, if we can identify here in the lower left-hand corner homologous recombination deficient cells, we can cause double-stranded DNA break by a PARP inhibitor. Again, PARP repairs single-stranded breaks. A pharmacologic inhibition of a single-stranded break causes a double-stranded break. And in an HR deficient cell here on the right, a double-stranded break goes unrepaired and leads to cell death. But in a normal cell here on the left, with functional homologous recombination, the cell survives. So that's the definition of synthetic lethality, right? Not just one, but both together is synthetically lethal and cause to cytotoxicity. So that really is the epiphany of PARP inhibitors in ovarian cancer. And as a result of this sort of homologous recombination deficient vulnerability, we can create a greater than 1,000-fold therapeutic index. Okay? And so we have to test, though, the germline and the tumor. We'll talk about that. Everything that's in the germline is in the tumor. In the tumor, I mean somatic. But everything that is in the tumor is not in the germline. So we have to test both. The germline really for the family and the tumor for the therapeutic opportunity. And the therapeutic opportunity is not just BRCA. It's beyond BRCA. And you can see that there are epigenetic inactivations of these BRCA-like genes, and there are also mutations. So it's not enough just to test for the mutations. So I created this Venn diagram. So at the bottom, BRCA mutations, which are all HRD, and then there are sort of BRCA inactivations, but then there's this sort of HRD-ness, and ultimately the PARP-ness, which is half of all ovarian cancers. So the most responsive to PARP inhibition are obviously BRCA, but the beyond BRCA, the HRD molecular signature creates a predictive biomarker. And there are two validated HRD opportunities. My choice on the left, which looks at the genomic scarring, which we call loss of heterozygosity, analysis of the telomeres, which are particularly sensitive to double-stranded DNA repair deficiency, telomeric imbalance, and then these large-scale straight-scale transitions, which are basically chunks of DNA. And that's created to a score, and it's 42. Anything over 42, and the company will give you the score. Another validated assay is the Foundation 1 loss of heterozygosity. That also does the genes and but also the loss of heterozygosity. So these are both validated assays. I can tell you that there are other labs that offer other assays, but they are not validated. So these are the 9 PARP inhibitor indications. We've been in this since December of 2014. There's obviously more to come, but I'm going to turn it over to Professor Secor and Angeles to talk to us about now the clinical data that is really informed by the mechanism of action and the molecular testing that I've described. So thank you, Angeles, and take it away.
Thank you, Brad, for the introduction, and so happy to be here. You know, this is one of the most exciting parts of our job is being able to give good news, and really the incorporation of PARP inhibitors into our clinical practice has been a very positive and beyond positive option for us and for our patients. You know, Brad, I think we've gotten really spoiled in all the recent FDA approvals for ovarian cancer. For a while, it seemed like a desert, and you have this great timeline showing the lack of approvals for really over a decade until we started seeing PARP approvals. And this is a very busy table, but it's a great summary for all of you to have these approvals across the PARP inhibitors listed here: olaparib in the first column, rucaparib in the middle, and niraparib at the far column. And not only is the treatment indication present for each drug, but also the maintenance indication, as well as the recommended dosage and approval dates. And across the board, these agents have been recommended for various treatment indications, as well as maintenance settings and frontline maintenance and platinum-sensitive maintenance. You'll see rucaparib in the middle is approved for maintenance in the platinum-sensitive setting, and we'll have to wait on the studies from the recent Athena trial to see if it gets approval in the frontline setting. There are some different caveats here, and we'll point some of those out, but really this table is a great summary. So we're going to discuss first-line maintenance in patients with newly diagnosed advanced ovarian cancer. I think, Brad, one of the most pivotal moments for me was the ESMO meeting in 2019. The year before, Dr. Katie Moore did a great job presenting the data from SOLO-1 and GOG 3004, which we'll go over, demonstrating that olaparib was a viable maintenance strategy in those patients. And then in 2019 at ESMO, we had 3 pivotal trials presented: Prima, Paola-1, as well as Velia, which is not shown here. But life really changed after that meeting because we demonstrated that in the frontline setting, PARP inhibitors were, in the maintenance setting, improved progression-free survival for patients. And we'll dive into those data further. Shown here is the schema for the SOLO-1 GOG 3004 study in patients with newly diagnosed chemo-naive disease and in stage 3 and 4 disease with germline or somatic BRCA mutations were randomized to either olaparib 300 milligrams twice daily or placebo. It was a 2-to-1 randomization. And I'm going to show you the initial data that was presented by Dr. Moore. And at 3 years, you can see that with the boxes here shown. is that the patients who were randomized to olaparib still were progression-free at 60.4% at 3 years, compared to 26.9% of patients who were in the placebo arm. There's a lot of interesting aspects of this slide, and I know that the audience is interested to see this data, and as well, Brad, I'm interested to hear your take too, but one of the most interesting things for me is the patients took the drug for 2 years, so 24 months. And at 3 years, you still see this tremendous benefit. And the majority of patients have now been off drug for a year. So I thought that was very interesting. And then the other aspect here is evaluating the placebo arm shown in orange is when you look over to the curve on the left, you can see that about 20% of patients, and these are all patients with germline or somatic BRCA mutations, that 20% had disease progression within 6 months, which is platinum-resistant disease. And that data was really concerning because most of the time we think these patients will do well. And now we're seeing that that's not necessarily the case. And then the third thing I got from this is even the patients who received olaparib, you can see that there is a small percentage, but about 5 to 10% of patients at like that 9-month mark had progressed on PARP. So we really also need to identify those patients who may have PARP inhibitor resistance de novo that may not benefit from these drugs. So just in terms of those 3 big items, those really stand out to me in this graph. What are your thoughts here?
Yeah, I think one of the most interesting things is that obviously the therapeutic benefit, but with long-term follow-up, there were no new cases of AML or MDS. But these patients, there is no increased rate, so they may be cured without the toxicity. Keep going. I'm loving this.
Yeah, I agree. And so when you look at the updated data here, and Dr. Banerjee presented this at the ESMO Congress last year, this is now long-term follow-up extending out to that 60-plus month time period. And at that point, you see that about 50% of those patients, it was 48% who were randomized to olaparib, still had not progressed, compared to 21% of those on the placebo arm who had not progressed. So, and you also see this flattening out of the curves going directly to your point, Brad, are we curing people? Which would be very exciting. So FDA actually approved olaparib for maintenance treating on the initial results that I presented. And this became an option for our patients who had germline BRCA mutations or somatic mutations. And, I think all of us have offered maintenance PARP inhibitors to our patients. And I just showed them the survival curves, which are pretty dramatic. And this information here is the safety overview. On the left, I know this is a busy slide. We really wanted to get all this information in there for you. But you can see the most common AEs, nausea, fatigue, and vomiting. And so that's really an important thing when you have a conversation with patients about starting PARP inhibitors. Just really lay out all these side effects for them, know what to expect, have mitigation strategies to reduce nausea. We talk about antiemetic use, also strategies to reduce fatigue. And there's some other side effects there that we really focus on as well, in terms of monitoring anemia, talking to them about the possibility of diarrhea and dyschezia, which is a taste issue some patients have. And then that middle bar graph, again, very busy, but demonstrating that majority of patients can stay on that starting dose of 300 milligrams BID. But I also have some patients that aren't able to. And with mitigation strategies and dose reductions, you can really keep the majority of your patients on these drugs. And then that last slide goes to what Brad just alluded to, is that the updated data demonstrate that the MDS AML rate is about 1.5%, which is really reassuring to see that in the frontline setting, and a little different than what we saw in the platinum-sensitive recurrent setting, and we're going to talk about that soon. So next slide here is the PRIMA data. The PRIMA data is a really interesting population because the way I like to see this is they took the worst of the worst who have ovarian cancer and then identified the best of those patients who have the worst disease. So essentially these patients had advanced stage disease. And if they had stage 3, they could have undergone primary debulking surgery, but they had to have visible residual disease. And then stage 4, they could go on regardless of their residual disease status. They had either a complete response or partial response after frontline therapy, and all tissue was sent for HR testing using My Choice. And for patients to be on, they also had a certain element in terms of their response to therapy. So there were some caveats there in terms of their CA-125. And they were randomized to either 200 or 300 milligrams of niraparib based on individualized dosing. We commonly refer to this as weights and plates, which I think is incredibly important for this drug, versus placebo. And shown here are the data. So on the left is a progression-free survival benefit in the HRD population. Again, another brilliant thing that was done with the study design is making that primary endpoint in the HRD population and then and also having that expanded endpoint for the overall population. And what we found in that biomarker positive population is that there was a significant reduction in disease progression. It was about 50+%. And you can see these differences in the survival curve. So that translated to about 22 months of progression-free survival compared to median progression-free survival of 10.4 months. And this was a BICR evaluation. And some of the other studies we've talked about using an investigator-assessed PFS. And then in terms of the overall population, you still see this benefit, not quite as strongly pronounced, but still statistically significant with clear separation in the curves. So going to the next, this is a little bit more complicated to dive down into. These lines, you'll see 4 lines on each graph. And essentially, the 2 initial survival curves are presented here, as well as updated analysis that, Brad, you presented at the 2020 SGO virtual meeting. And one of the groups was adjusted using a Cox regression method, and essentially demonstrated similar findings. So in the HRD population that had BRCA mutations, you see again the significant benefit in terms of improved progression-free survival with a hazard ratio of 0.40. And in the individuals who have an intact BRCA wild-type gene but are HRD or genomic instability positive, you still see this improvement in progression-free survival with a hazard ratio of 0.50. But what is very interesting in the study is this curve all the way to the right, and that's your HR proficient curve. And this is one of the only studies that demonstrated in the frontline setting when you utilized a PARP inhibitor that there was still a significant improvement in progression-free survival. And you can see that the difference is not as profound compared to the other biomarker groups, but it translates to about a 32% reduction in disease progression. So I kind of wonder to myself often in evaluating this data, why is that? And I'm going to get Brad's opinion here in just a second, but I want to go to the next study. Before I go to the next study, I'm going to talk about this first. So niraparib was approved by the FDA in April 2020 for all patients in the frontline maintenance setting who have advanced ovarian, tubal, or peritoneal cancer who had a CR or PR after platinum-based therapy. So now I want to talk about the individualized dosing of niraparib, which is the weights and plates. I really love this. I think it was really incredibly important to identify these individualized factors, and this is based on weight and platelets. So if somebody weighs less than 77 kilos or they have platelets less than 150,000, you want to start them at a reduced dose of 200 milligrams daily compared to 300 milligrams daily. But the individualized dosing has made a huge difference in the incidence of significant thrombocytopenia. And you see that here in this table. So with the fixed standard dosing, the incidence of thrombocytopenia equal to or greater than grade 3 was 48%. But if you use the individualized dosing, that's reduced dramatically down to 21%. So I find this really helpful and utilize this clinically all the time. So Brad, any comments there?
No, I just think, we have many overlapping indications, and maybe we can get into this in the discussion, but it's challenging when the indications overlap. So, for BRCA, we have SOLO-1 and PRIMA, you just showed us, and you're going to show us we even have PALA-1. So sometimes it's challenging when the indications overlap, and we can talk about that in the discussion, but it's nice to have options for patients.
Yep, and we are going to have a summary table very soon, and that's a perfect segue into PALA-1. PALA-1, similar type design, but it was all newly advanced stage 3 and stage 4 patients, and stratification was performed based on BRCA mutation status. Additional assessment of HRD was also performed here, and patients were randomized to either olaparib plus bevacizumab or placebo plus bevacizumab. So to be a part of the study, patients had to have at least 3 cycles of bevacizumab. And shown here are the survival curves for these different groups. So the first survival curve includes HRD positive patients, including those with BRCA mutations. And again, wide separation of the curves, dramatic improvement in progression-free survival. When you exclude those patients who have a BRCA mutation, you still see a similar improvement in progression-free survival with wide variance there. But when you get to that HRD unknown, or really this is also that HR proficient group, there's overlap of the curves. And this is what was different than the curves that I showed you with the PRIMA study. My opinion, Brad, is I don't really think this is due to a difference in the PARP inhibitor. I mean, that can be debated, obviously, but this may be due to some subtle differences in study design. And also the bevacizumab component here makes it more challenging to assess head-to-head. Shown here are the treatment emergent events. And what you can see is that the incidence of grade 3 treatment emergent events were similar, but with regard to hypertension, there was less issues with hypertension in the olaparib and bevacizumab arm compared to bevacizumab alone. I thought that was very interesting. The serious adverse events were similar, but there was slightly more treatment discontinuations with olaparib and bev than bev alone. And I think part of this is probably we've gotten more used to managing bevacizumab-related side effects, so we feel pretty comfortable with that, whereas we're still learning about PARP inhibitor side effects. And this combination of olaparib plus bevacizumab as a first-line maintenance treatment option was FDA approved in 2020 as well. So now we have several options. This is what Brad was talking about. So in the frontline ovarian cancer setting for BRCA-associated cancers, we have olaparib switch maintenance. We have a niraparib switch maintenance based on PRIMA. And then for HRD positive, niraparib switch maintenance, or you could go with olaparib plus bevacizumab. And then with the HR proficient group, the options are bevacizumab after chemotherapy, or niraparib switch maintenance, or no maintenance. In my opinion, it's really this HRP group that demonstrates the greatest unmet need. This is where we need to really strive to identify novel therapies. So in the interest of time, I'm going to keep moving, but I'm hoping that we can have that discussion with the audience interaction soon. In terms of maintenance trials in the platinum-resistant setting, this is really where it started. There's a lot of studies that have been done in this space, including Study 19, Solo 2 for olaparib, NOVA for niraparib, and Ariel 3 for rucaparib. And this data actually was presented all the way back. I don't remember if it was 2011 or 2012 when Dr. Letterman presented the data at ASCO, but that was the first time I've seen such a dramatic hazard ratio and survival curve, which is very exciting. And then these other studies were reported out in 2016 and 2014 in terms of their paper publications. This is a table that is very busy, but I think helpful to show the data. But what's most important here is highlighted in that red box is that if you do not treat patients with a maintenance strategy, and that may certainly be fine. I think this is a patient preference issue and a discussion and counseling issue. But what I can now tell patients, because there's such uniformity across all these trials, is that if we choose to go with an observation strategy, they'll have approximately 5 months before disease progression. And it's very strikingly similar performance of the control arm here. Shown here is the final analysis of overall survival for Solo 2. This was presented by Dr. Proveda at ASCO in 2020. And remember, Solo 2 was a study specifically for patients who had BRCA mutations and were treated with a olaparib maintenance strategy. And what is shown here is that there's a significant numerical difference. Patients who were treated with the olaparib arm had a median overall survival of 51.7 months compared to 38.8 months, so really a year difference. In the initial analysis, the hazard ratio upper limit went all the way to 1, and the p-value was 0.0537, so it didn't quite attain statistical significance. But there's a lot of issues with crossover here and loss of follow-up. So they did some initial sensitivity analysis, I'll call it that for lack of a better word. When they did the overall survival analysis per electronic CRF of the full data set, the hazard ratio was 0.70, so a 30% reduction in death, and the upper limit of that confidence interval was 0.96. And in an additional overall survival analysis of the olaparib group, they found similar findings. So, certainly very important to share this data with patients. It looks like these curves are coming closer and closer together, but my opinion in doing, my partner, Dr. Laura Havrilesky, does a lot of patient preferences work. 12 months is of substantial importance to our patients. So this data demonstrates that you had over 20% of patients, it was 22% of patients who were still receiving olaparib at 5 years, which is pretty remarkable. Shown here is the initial data from NOVA 3 trial, which is interesting in terms of this trial design. It was a germline BRCA mutation cohort and then a non-germline BRCA mutation cohort. And that non-germline BRCA mutation cohort included patients who had somatic BRCA mutations. So just kind of remember that. In the survival curve all the way to the left, you see again this wide stratification in progression-free survival. The hazard ratio here was 0.27. This is at 21 versus 5.5 months. This was a BICR analysis, which is again a little different than some of the other studies I'll show you. And then in the non-germline cohort overall, now this is going to include patients who are somatic BRCA mutation have containing tumors, patients who are HRD positive, as well as those who are HR proficient or unknown. And the hazard ratio here was 0.45, so a 55% reduction in disease progression. The actual medians were 9.3 versus 3.9 months. And then when you evaluated that specifically in patients who had the non-germline HRD positive, you saw a wider difference here, hazard ratio 0.36 with a 12.9 versus 3.8 months. When you dive down, and we didn't show you this data, but dive down to those patients specifically who are HR proficient, I think the median difference was much smaller, maybe 3 months, but again, the area under the curve of these survival curves was still substantially different. So, it's a little bit of a challenge sometimes in this situation for that group who has homologous recombination proficient. There's a lot of discussion about what's the best biomarker. We need work on these biomarkers still. We need to find a functional biomarker of homologous recombination deficiency, which we don't quite have yet. But at least this information helps us discuss with patients the magnitude of benefit. Up here is the PFS2 data that Dr. Machulonis just presented at our SGO 2021 virtual meeting. And what you see in the non-germline mutation cohort is that the PFS2 survival curves are very similar, no significant difference. But in that germline BRCA mutation cohort, you still see this difference in the PFS2 survival curves, and that just supports the primary endpoint. This study was challenging again because of the crossover effect. And I would say it's not just crossover to PARP inhibitors, but crossover to other drugs that our patients with ovarian, tubal, and peritoneal cancer can receive. And there's also loss of follow-up in terms of data points. In terms of the overall survival, very busy slide. There was no significant difference in overall survival in patients who had the non-germline BRCA in cohort. In the germline BRCA mutation cohort, there is a trend, and it was about a 9.7 months improvement in survival outcomes in those patients who were randomized to niraparib. When I look at this data, there's several things I get out of this data. But one is, it's why do I treat patients with a PARP inhibitor? It's really more based on the progression-free survival data. I think the overall survival data here certainly supports the use of a PARP inhibitor. In the non-germline mutation group, it's a little bit more challenging. I think the lack of difference in overall survival, I guess is complicated because of the crossover effect, but also it also demonstrates that there may be opportunities to continue to do clinical trials in this group of patients in that setting indication rather than wait for PARP exposure. This is the Ariel 3 data, which was evaluating rucaparib compared to placebo. Again, compared to all the other studies, you see the significant improvement in progression-free survival with a hazard ratio of 0.23. And then I just want to spend some time on how these patients are treated in a relapsed setting where you're using not maintenance but treatment. Solo 3 was a very interesting trial where patients with relapsed cancer could and a BRCA mutation could be randomized to either olaparib versus a non-platinum chemotherapy. And shown here, you had a objective response rate of 72.2% in the olaparib arm compared to 51.4% chemotherapy arm. There's some challenges to that study. And then with GY004, this was a platinum-sensitive trial where patients were randomized to either platinum-based chemotherapy that addressed one of the concerns in Solo 3 that these patients didn't get platinum, they got non-platinum agents compared to olaparib single agent or the combination. And what we showed here is the ITT, so intent to treat group, as well as the germline group. And I just want to focus on the germline mutation group is with chemotherapy, response rates were 71%, with cediranib and olaparib, 89%, and with olaparib, 90%. So response rates are incredibly high with this targeted therapy for this patient population with that specific biomarker. And Aerial 4 was just presented at SGO, now comparing rucaparib to standard of care chemotherapy. Either it could be patients with intermediate platinum sensitivity received paclitaxel, and if they had platinum sensitive disease beyond, I think it was 12 months, then it was a platinum-based doublet. And findings here demonstrated prolonged progression-free survival in the rucaparib group, 7.4 months versus, I think it was 5 months in the chemotherapy arm, statistically significant. But what was really, and this was really interesting data, it supports the other findings that we saw with Aerial 3 and GY004, as well as Study 12, which we don't have mentioned here. But also, I want to show this really interesting curve to the right, because in patients who had a BRCA reversion mutation, they actually did not do as well when they were treated with a PARP inhibitor. Their progression-free survival was 2.9 months compared to 5.5 months with chemotherapy, indicating that BRCA reversion mutations may be a primary marker for PARP resistance. So here's a very interesting slide. We've got maintenance platinum or maintenance therapy in the platinum-sensitive populations around the world. These are slides that are being conducted by our Asian colleagues in China. And what you see here is that evaluation of niraparib in the platinum-sensitive group, as well as a novel PARP inhibitor called fluzoparib, demonstrated similar outcomes compared to what we're seeing in the United States in terms of improved progression-free survival. I'm not going to get into the nuances of these studies, but just showing that this drug works across these different racial groups is incredibly important. So let's talk about a patient case. You ready? All right. It's a 58-year-old patient with newly diagnosed stage 4 high-grade serous ovarian cancer. She's been treated with carboplatin and paclitaxel, and let's just say she's had an excellent response to chemotherapy and surgery. She has a germline BRCA mutation that's been identified. She's completed all of her chemotherapy. She's asking you about questions, and her hemoglobin is 7.8. And so, Brad, what are your thoughts here in terms of utilizing a PARP inhibitor as an appropriate option?
Yeah, I guess I want to start by thanking you for that fair, balanced, succinct, and on-time presentations. That's wonderful. Every time I tell a patient that she has a BRCA mutation, she's sad. And she should be happy, right? Because now we can go through the family and prevent these cancers, and we have great treatment options. So, and I just to be clear, germline testing, probably panel testing, is recommended by every society. And also that if she's germline negative, she's not, she should have tumor testing, because if you find the BRCA gene in the tumor in a predictive way, it means the same. So this patient, no question, needs a PARP inhibitor. You're not supposed to do it until all toxicities are grade 1. I probably wouldn't transfuse her, and 7.8, as long as she's asymptomatic, go ahead and sort of ignore that. But this patient has sort of 3 good options: SOLO1, olaparib, Prima, niraparib, or the combination olaparib bevacizumab a la PALA-1. So I'm going to sort of, I can tell you what my preference would be. I'll just tell you, my preference PALA-1. I like SOLO-1, but I think that the cure rates might be higher with PALA-1, and so I'm going for cure here, and SOLO-1 is great, but I think PALA-1 is a little better. What do you think?
Wow. Well, this is incredibly challenging, because I wish there was another arm to PALA-1, but we can't go back in time and change that, right? So I really wish there was an olaparib only arm. And I think it's very challenging in lieu of not having that arm to determine if there's truly a benefit to doing the olaparib bevacizumab doublet. So what I determine my treatment options with is how this patient was treated up front, and if we utilized a bevacizumab strategy or not. I tend not to use bevacizumab universally for our patients with ovarian tubular peritoneal cancer. I utilize bevacizumab based on certain factors. So, and that's really based on the ICON studies. But if they have suboptimal stage 3 disease, or they have stage 4 disease, and there's no contraindications to bevacizumab, then I'll utilize bevacizumab. And in that patient population that has a BRCA mutation, I'll typically treat with a combination with a PARP inhibitor, rather than using a PARP inhibitor only. If they haven't received bevacizumab, I'm not going to start it in the maintenance setting. And then in that situation, it becomes a lot more difficult about counseling. So I do feel like it's important to discuss the different studies that are available, whether it's niraparib or olaparib. And I talk to the patients about the different dosing strategies. Essentially, I go through all of those drugs with them, the side effect profiles, the dosing, and then a lot of our patients, I find they're in chat rooms. They're talking to other patients and they're saying, well, my friend thinks this one's the best one. But then they'll come back and say, after reviewing all this information, this is the PARP inhibitor I want to go with. So I find that in the frontline setting, I am prescribing all those various different options. I wanted to bring this case up, though, because I have a lot of patients that once they finish their therapy, they want to get started on that PARP inhibitor right away. And this is often a scenario, maybe not a hemoglobin of 7.8, but often a hemoglobin of 8. And, in the package inserts for PARP inhibitors, for 2 of them, it states that you need to resolve toxicity to grade 1. But you also have a little bit of a window there, like up to 8 weeks, that I think is reasonable to treat. So I kind of like to see these patients back in about 4 weeks, check all their labs, make sure they've recovered substantially from their anemia before I start the PARP inhibitor.
Yeah, that was great. And I want the audience, we didn't script this, right? We agree. Stage 4 patient, you said it, needs Bev, and she's BRCA, so I would layer olaparib in the maintenance phase. So I think this decision, bevacizumab, yes, no, and you really outlined it very well, and I think that's the common approach sort of in the high-risk patient. But once you go down that bevacizumab road, if she's HRD or BRCA, you add olaparib, and if she's not, you keep the bevacizumab going. So I want to just discuss the HRP patient who's not on Bev, right? Because that is going to be a large proportion of patients, because remember, HRD or BRCA together is about half the patients. And if you don't start Bev, then you have to make the key decision in the maintenance phase, since there's no Bev. Do you do prima, niraparib, or observation? There's absolutely no right answer here, but I'd like to sort of have you, walk us through that, Angeles, how you handle that HRP no Bev patient observation.
This is a group that really we need attention to. We need clinical trials that are directed for this patient population. And I do think that this is an opportunity, again, it's having a discussion saying this is the drug, these are the side effects, this is the benefit that was seen in this trial, and if they're interested. And, I mentioned my partner, Dr. Laura Havaleski, before. She's done a lot of great work regarding patient preferences. And I think it's really important to have this discussion. I'll have some patients that it's absolutely no-brainer. They want to do niraparib. But then I've also had other patients that aren't really interested in utilizing a PARP inhibitor in that situation. It's challenging. But Brad, I think we get so spoiled at some of our academic centers or your center where you're just a powerhouse in doing clinical trials, where we have clinical trials that we can offer patients. So it's not often that I have to have this discussion because a lot of our folks are on trials.
But that's the right answer, right? In the, we have reasonable medicines, not good enough in the HRD subset. And if you're Bev, olaparib or not, niraparib, or if it's BRCA, you can do either one again. But in the HRP patient, which is half, the right answer absolutely is a clinical trial. And I'll show you in the next session some options for that. So I'm very grateful for that. The last sort of thing that I'd like to talk about before we move to the next session is, let me make a statement first. So the predictors of PARP sensitivity are molecular signature, we're talking about it, and number of lines of therapy, and we spent a lot of time. This is, your first line is always the best option. But then platinum sensitivity, because platinum sensitivity is also a biomarker, just not a molecular biomarker. And in the platinum sensitive maintenance phase, you went through the NOVA, the Ariel 3, the Solo 2, and the Study 19, and very beautiful job. But if you have a patient who you say, look, I'm going to go ahead, she responded to second line or third line platinum, I'm going to give a maintenance PARP, all 3 are approved. That now, as I sort of in the beginning alluded to, that's a tough decision. How do you make that decision when you have 3 very nice studies, very nice agents, you've decided on a PARP, but then you have to decide which one? Tell us how you work out that decision.
Yeah, I go back to, what I told you before. I talk to my patients about all three of those different options. I find that a lot of individuals, because they are in chat rooms, they're talking to the other patients, they sometimes will have a bias one way or the other. So after discussing the various side effects to the medications, we have this really nice thing in Epic where you could put the information about all three drugs on Epic and they can read it, or you can print it out for them. They review it, and then we have a visit together, and they tell me, which one they're most interested in.
I think all of you know, listening, and you, Angela, I'm a fan of all three medications. I've published on all three medications, and I use all three medications. But in this unique setting, we're starting, and you told us, we're starting most patients now with niraparib at 200. And that really gives us only one dose reduction to 100. So that makes me concerned. You also said, I got all this familiarity with olaparib. Olaparib has 7 indications, 4 in ovarian, and then obviously breast, pancreatic, and prostate. So I got a lot of familiarity. Rucaparib has 3 strengths of their medications, 300, 250, and 200. And they have 4 doses, 600, 500, 400, 300. So in this sort of aerial 3 platinum-sensitive maintenance, if that resonates with you, the dosing flexibility, if you will, then rucaparib is a good choice. I get it. Rucaparib has some liver enzyme elevations, might even have some photosensitivity, although no one goes in the sun anymore because they don't want to get melanoma. We actually get less sun exposure here in Arizona because we're afraid of it.
So these are just common adverse events with PARP inhibitors in ovarian cancer. So, reviewing the hematologic, neutropenia, really clinically not often relevant. I haven't found this to be clinically an issue. Anemia does occur. I usually do an evaluation if somebody becomes anemic, iron studies, folate, B12. I think very rarely have I ever had to transfuse anybody. I would say once. And a lot of times that workup is negative. It's just a study effect. And sometimes it does turn out that you pick up a deficiency in, I would say iron or folate, probably the most common, that you can supplement that. Thrombocytopenia, we've talked about already. We've also talked about the non-hematologic. So with nausea and vomiting, these drugs, rucaparib you mentioned, you can actually take rucaparib with or without food, but some of the other agents you need to wait 30 minutes before you take the PARP inhibitor. And I usually recommend using an antiemetic strategy about 30 minutes before taking the PARP inhibitor. My most common go-tos are ondansetron or olanzapine. And then fatigue, I have had to do a dose interruption for about 2 weeks with fatigue and then start back at that prior dose or do a dose modification. Diarrhea, constipation can be problematic but easily manageable. And then we talked about the rare AML MDS. I forgot to mention in the platinum sensitive setting, AML MDS seems to be a little bit higher. Dr. Preveda reported about 8% in patients who had germline BRCA mutations. And the updated analysis just presented SGO, I think it was 6.7% for I think it was niraparib. So it does seem to be that if you've been previously exposed to chemotherapy, probably those platinum agents, and I would gather probably topotecan and liposomal doxorubicin may have a higher risk of AML and MDS. But something to really monitor, if your patient doesn't recover their counts within 4 weeks and you're concerned, I would send them to a hematologist for further evaluation. Pneumonitis is a very rare complication, most notable in the olaparib, probably less than 2%. But have this on the on the horizon, thinking about if you have a patient who presents with dyspnea. All right, Brad. So key takeaways. I think you covered a lot of this already in terms of, consider use for patients who have advanced high-grade ovarian cancer in the frontline setting, as well as those, with newly diagnosed disease and platinum-sensitive disease. I think for me personally, I like testing for BRCA and HRD status. I'm so spoiled at Duke. We do germline and somatic testing on patients who are newly diagnosed, and it's pretty, automatic. We have some studies that my partners are running. Dr. Watson, Dr. Moss, and Dr. Previs are all involved. And then for me, I think this important point here is discussion and shared decision-making with patients is critical. All right.
Yeah, if those are really the ASCO guidelines, even though you said they're the key takeaways. So Bill, too, published in the JCO, the ASCO guidelines, which I think are helpful. I wanted to take this one question from the audience. How do you feel about PARP after PARP? Can PARPs be used again?
Yeah, great challenge, Brad. This is a situation where I wish we had a clinical trial, and that clinical trial really needed to be happening, 6 months ago. But this is an issue that we're dealing with clinically all the time. There are some interesting evaluations being conducted in clinical trials. There was the Evolve trial evaluating cediranib plus olaparib. There's the EFFORT trial with olaparib and WEE1 inhibitor, and then the SOLAR trial with olaparib and selumetinib. They have demonstrated some, potential anti-tumor activity with these combinations, but I don't think these combinations are not ready for prime time, unfortunately. And I have utilized a PARP inhibitor in the maintenance strategy after PARP, but it was somebody who had a fairly long interval after they started PARP maintenance therapy. They did progress on a PARP inhibitor for maintenance, and then we repeated platinum-based chemotherapy. She had a complete response, and we tried the PARP inhibitor again. So I have done it. I know that it's not really supported by the current data. But there's a lot of hard decisions to make, Do you use a PARP inhibitor for maintenance? Do you use bevacizumab for maintenance? And we really need a trial.
Yeah, thank you. I have another question here about combinations. So I think that leads into our very short next section. What's next? What are the future frontiers? And I'm very honored to work with Angeles and the GOG leadership, also NRG. So these are trials that we're collaborating on together. The studies that are abbreviated GY are energy studies. We try to brand our studies. These others are generally GOG partner studies. KeyLink, First, Duo, and Athena are all PARP IO studies in some sort of configuration. So all phase 3 trials. So they're not really recruiting. They're ongoing. Some of them have finished recruitment, but we don't have any results. We also have some small phase 1-2, Mediola in the platinum sensitive, Avanova triplet, which as you see is now all of a sudden PARP, a checkpoint, but also bevacizumab. And even the frontline trials have an anti-angiogenic frequently, and then some platinum resistant ones, which are outlined here. So this is definitely evolving landscape. And really what it does is it takes the checkpoint inhibitor, generally an anti-PD-1 or PD-1, and adds it to a PARP. But we also have bevacizumab. We added bevacizumab, as you know, to atezolizumab, Imagine 50, presented at ESMO as completely negative. I mean, maybe there was a little bit of a predictive opportunity with the PD-L1 expression, but it did not meet its primary endpoint. So we're now looking at IO PARP rather than IO Bev, and there's also an opportunity to do all three. So KeyLink is an opportunity in the studies. So Bev, Nivolumab, Avanova, and Topacia sort of speak to these combinations. We're wondering that as this Venn diagram points out that maybe the sweet spot is all three. So KeyLink is very close to finishing enrollment. You can see very robust study. It takes the BRCA patients out, but includes all the rest in pembrolizumab, olaparib, and then bevacizumab is optional. So that's an exciting one. You already talked about these combinations of PARP DDR. You mentioned WEE1. There are others. But I think we're also learning that beyond angiogenesis, PARP, and IO, there's other opportunities. And I want to talk to you about one of these tumor treating fields. Antibody drug conjugates is the next wave. So again, Bev, PARP, IO. What's next? Tumor treating fields and antibody drug conjugates. And I'd be remiss if I didn't mention this. So 3, tumor treating fields, antibody drug conjugates, and this sort of MUC16 antibody. You're actually the global PI for this. Why don't you speak to 3035, which you call Flora 5, frontline trial.
Great. So the Flora 5 trial is evaluating origovimab. Origovimab is a really interesting drug. It's a mirroring monoclonal antibody that really functions in antigen presentation of CA125. So it's basically enhancing the immune response. It's been evaluated in several different settings, and you probably are very familiar with the maintenance trials that were done with this agent. That in a phase 3 study was negative, but then and in that study it was purely maintenance. It was after chemotherapy. And one of the issues with that study is that this drug relies on CA-125 to be elevated for it to work. Well, in the maintenance strategy, CA-125 is not going to be as relevant, right? Because hopefully it's negative. And so I think that's probably one of the reasons it didn't work. But in a phase 2 trial with the survival curves to the right, you saw this improvement with progression-free survival of 41.8 months versus 12 months in the group that didn't receive orogovimab with chemotherapy. And in that study, overall survival had not been reached yet compared to 43 months, which is what you'd expect in the control arm. So this is the phase 3 registration trial building on this phase 2 study. So we're very excited about this trial. This trial does not allow bevacizumab to be utilized. Brad, you were part of those discussions. We really thought about this a lot because there, as you mentioned, there is some potential data about benefit of anti-angiogenic agents with immune therapy. But as I mentioned, this was really building on the phase 3 study or the phase 2 study that did not include bevacizumab. So if you're interested in this trial, just reach out to me. We're happy to get you into the system. We're still looking for a few more sites.
Yeah, so to your point, so HRP is half the population. The best approach to HRP is a clinical trial. And which clinical trial? That one. So this really fits into our conversation, and hopefully this addresses the need. This is the 2 study cohorts, the primary debulking cohort and the neoadjuvant cohort. And you can see that the investigational agent is giving on cycle 1, 3, 5, and then in maintenance. So this is very exciting. I hope that is an important option for patients in the future. But I want to talk to you about tumor treating fields. Tumor treating fields look at a level of electromagnetic radiation that is in the spectrum that interferes with mitotic division. So mitotic function, cell division. So if you apply these tumor treating fields, they can prevent the cells from dividing. You strap these arrays, carry a little battery pack on your back. You say, Monk, come on, man, that's crazy. That we're going to do this low-level electromagnetic field and we're going to interfere with the microtubules. This has 3 positive phase 3 trials in the most chemotherapy-resistant solid tumors. 2 in GBM, glioblastoma multiforme, and 1 in thoracic mesothelioma, and all 3 had a survival advantage. So although the science may not be familiar to you, there is definitely proof of principle. And it comes from a long history of science looking at frequency-dependent effects of tumor-treating fields. So the trick was to identify the frequency that is effective in treating this. These are lung studies. In fact, there was recently a press release on lung data, and you can really see in all sorts of cell lines. You see the glioma cell line here. It works. And so the preclinical data is aligned with the therapeutic data, which doesn't always happen. And so that really is a wonderful opportunity. So there was a sort of a feasibility study that was done by Professor Vergote in Belgium. And I have a picture here of the sort of the device. You can see it's strapped on. We actually place them preferentially where the tumor is, and it can be directed to the pelvis or the upper abdomen and that sort of thing. And because weekly paclitaxel is very impactful in mitoses, there's a synergy. So we needed to do sort of a feasibility study, again, at the electromagnetic frequency, 2,000 kilohertz, 200 kilohertz, where it made sense from the preclinical information. So this study has been published, and we saw a very nice versus historical control, prolongation and progression-free survival and overall survival. You see the median PFS for the paclitaxel was about 9. In our other studies, it's been about half that. And so we're very excited, and 1-year survival of 61%, which is greater than what we're accustomed to. So this was the stimulus to launch Innovate 3. But this is a GOG study, and it's enrolling well. Weekly paclitaxel with or without. The primary endpoint is overall survival, and really excited about it. This is novel, and this has nothing to do with PARP. This has nothing to do with Bev. And sort of like antibody drug conjugates, we create a unique opportunity, which is what we're trying to do in recurrent ovarian cancer. So this is the chest torso safety. Again, it's already been proven. So this is an antibody drug conjugate, mirvetuximab soravtansine against the folate receptor, again, versus physician's choice chemotherapy, paclitaxel, liposomal rubicin, or topotecan, a global study, a GOG study, and we're excited about that. And then finally, another study, which is a decoy for AXL, which is a molecule that drives chemotherapy resistance, also recently opened within the GOG 3059. So we bind and inactivate AXL, which interacts with Gas6, and then ultimately we overcome resistance to paclitaxel. So it really is a wonderful paradigm. Even I, who live it every day, need to sort of reset and think about it. I actually, on my desk in my clinic, I have a roadmap, if you will. So every therapeutic decision I make, I'm like, oh, is this patient eligible for a clinical trial? And then I refresh my memory with sort of the roadmap that's on my desk. And that's really how you create a culture of clinical trial enrollment. So combination therapy with PARPs are ongoing. Talked about immunotherapy, anti-angiogenics, and then novel therapy, origovimab, tumor treating fields, antibody drug conjugates, and then a decoy for AXL. So that really is a wonderful thing. Go ahead, Angeles.
Yeah, Brad, can I add on another trial that I really like is GOG 3018 with VBL 111 and paclitaxel. Recently, there was a paper regarding CA-125 responses in patients. Again, they couldn't evaluate that based on each arm of therapy. I was fortunate to be one of the authors on that paper, and we've had several patients on the study at Duke. What's very interesting is how well tolerated this drug is. So I like the ideas of drugs enhancing tumor efficacy, but not causing a lot of side effects, right? Because I think quality of life is so incredibly important for our patients.
Yeah, I didn't put that in here, but VBL, the study is called OVAL. It's an adenovirus gene therapy. It's the same adenovirus that the J&J COVID-19 vaccine is. And what it does is it selectively targets the endothelial cells and is an anti-angiogenic. So by doing that, it also creates a local inflammation and potentially even enhances the immune response. So that's something, and thank you for reminding me. That's another study that I'm very passionate about. So the clear treatment for these patients in the highest unmet need, HRP, and platinum-resistant recurrent ovarian cancer is a clinical trial. So when you put your patient on a clinical trial, you are always compliant with the NCCN because that's the preferred approach. Other comments, Angeles?
Yeah, no, absolutely. I agree. Exciting to see so many different opportunities being developed.
It is, and I really thank the audience. I'm very grateful, Angeles, for you for taking time out of your busy schedule for the preparation of the slides. So thank you for joining us. Angeles, good seeing you again, and hope to see you in person very soon. Thank you, and so long.
Yeah, absolutely. Thank you, Brad, for inviting me. This was really wonderful.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.